we would like to start by just having a few words from John Cannell, who's one of the scholars who has done a lot of work on David's work with David, and would like to just have him tell you a little bit about Easton's work and his importance for political and social science. John?
Good. I thought we were introducing the introducer, Harry. In 1953, David published a book called The Political System, in which he presented a very comprehensive and some people thought scathing critique of the discipline of political science or its current state. One prominent scholar at that point, however, who was dissatisfied with the state of the discipline, said the book was really the autobiography of a generation. And for those of us who were confronted with the positive character of David's vision for political science, the book became the autobiography of the next generation. I spent a lot of my early academic career criticizing the image of science that had been adopted by the behavioral revolution of political science. And since David had turned out to be the major spokesperson and the exponent of that of behavioralism, he was often my target. However, I'd never met David Easton, and so I criticized him from afar. But then, by chance, we met in 1985 in Finland, and to make a very long story very short, we became close friends, and I ended up conducting his extensive oral history. During the following years, we joined in a project to advance the scholarship on the history of political science. And in my own historical ventures and my concern with David's life, I learned quite a bit about the history of the field. And one of the things that I learned that was very consistent throughout the history of the field was that the pursuit of science was always for the purpose of advancing some ethical or moral principle. That the commitment to science was really grounded in the belief that political science had the cognitive authority, to use Harold Lasswell's word, speak truth to power, that it would be able to be a guide to public policy. It's sometimes seemed, I think, that political scientists, particularly today, have often forgotten why they're committed to science. And sometimes they, I think, rather severely mistook the methodology of natural science. But if one revisits a number of the crucial points in the history of the discipline, such as the founding of the American Political Science Association, it becomes quite clear that science was an instrument for achieving a more progressive ideology in politics and advancing the democratic ethic. And if we look at the distance between academic discourse and political discourse in the United States, it's easy to come to the conclusion that it was rather a utopian dream that political science would ever be in a position to guide political life. But from the formation of the APSA to David's choice to pursue in his early life political science rather than a career in law, to the 1960 protest against a sort of apolitical scientism in the discipline, to David's 1969 presidential address in which he called for a new revolution with greater political relevance, there has been an enduring hope, really, that political science would matter politically. I recently presented a paper tracing the evolution of the systems concept in David's work from the time he was an undergraduate in the late 1930s until he published the System Analysis of Political Life in 1965. And the consistent theme that I found was an unswerving belief that the pursuit of science was for the purpose of informing public values, and particularly the democratic ethic. And so I think, tonight it's only fitting that this series of lectures is devoted to that purpose, and I think it's exemplified in the work of tonight's speaker, Dr. Cheryl Koopman, who will be introduced by you.
Well, I'm glad that John highlighted the particular particular aspects of David's works that he did, because the work itself is very rich and it can go in many different directions. But one of the important aspects of it was dealing with the nature of science and scientific discovery. And one of the things that we're going to discuss tonight, one of the reasons that we asked Cheryl as the Easton lecturer, is because she's very concerned with the question of how scientific knowledge is diffused and becomes integrated by the experts who are dealing with the particular problems, in this case medical problems, as well as by the public and by the public health community. So that we find that as you think about Lyme disease, for example, which is what she's going to be discussing much of this evening, that there are experts who disagree about what it is, how it should be treated, how you design paradigms and models to actually test for it, and how you achieve questions of unity in terms of how the experts are going to be treating what seems to the public a simple disease, and then how you have public health policies that go from there. So there are lots of interesting questions that you get into as to how a scientific community gets new studies using a new paradigm, how a new paradigm breaks into the field, how you get answers, how you address the public concerns, particularly when there are fears of an epidemic, particularly if there's an epidemic that may be something that has negative stigma attached to, how you get enough expert unity to go out into the public and tell them what kinds of health policies you need to use. So that I think the example could be found in many different types of diseases, from cholera and plague to AIDS, but I think Cheryl will be speaking mostly about Lyme disease tonight. But the general topic, I think, is one of great concern for people both in medicine, public health, biology, science in general, however you define that field. And so Cheryl is going to be speaking tonight on politics, psychology, and ethics in understanding infectious diseases. She's a professor of psychiatry and behavioral sciences at Stanford University. She served as past president of the International Society of Clinical Psychology and is one of the top researchers in this area. So I ask you to welcome her to the talk. Thank you.
Thank you very much. I'm giving this particular talk because it's something that I'm just totally fascinated with right now. I'm very absorbed in trying to figure it out. And so I truly will be interested in your questions and your comments at the end. And we have Lorraine Johnson following me to give a few minutes of commentary as well. Today, the structure of my talk is to just briefly give an introduction with going right into some lessons from history to just make ourselves remember how important the conceptualization of a disease is. And I'll be focusing on a few examples, some historical examples, the bubonic plague, syphilis, which is still here, but we actually have plagues still here too. But you know, the history of figuring these things out and developing a shared understanding among scientists, practitioners, policymakers. I'll mention a little bit about AIDS, and then I really will focus the core on Lyme disease, which is an incredibly contentious illness from a conceptual point of view in the United States and Canada, Europe. In some parts of the world really haven't focused on it very much, so there's not much conflict. I recently gave a talk in New Zealand, and virtually no one in the audience had heard of it. So it's not everywhere where there's this conflict, but it's certainly very, very prominent in, especially in northern temperate zones. And then I'm going to conclude with some ideas about what we can do, trying to analyze what might be going wrong when we have these diverse views that are very, very much in disagreement with each other. Very little research to try to bring together a common understanding. And I'm going to make a very primitive attempt to apply Christine Monroe's theory of moral development, moral reasoning, to some of the concepts here. I haven't gotten feedback from her deliberately because I wanted to see if I could take what she has recently published in 2012 as a beginning of a moral theory to try to see if we can get some insights thinking about this particular problem. And I'm going to conclude with some practical implications, some new ideas that I've just come across that might make a difference, and we'll end there. Okay. So even though the topic is infectious diseases, really the focus is on serious diseases that are affecting a lot of people. Even though we probably don't know everything there is to know about things like colds, and maybe there are some serious consequences we don't know about yet, we're really going to be focusing on some illnesses that are causing profound suffering. And so right there you know that there's ethical implications when so many people are suffering from some of these illnesses which at least initially are not being understood. I just used this image of a I think it's a gorilla, trying to figure something out to remind us that what we have to do whenever we encounter a new illness is we have to figure it out, just like the more primitive animals. And there's a lot of factors that can influence how we figure it out. And so history gives us lots of examples of where we were figuring it out incorrectly, and sometimes just because microscopes hadn't been invented and concepts weren't there. It wasn't people's fault, but I'll just review quickly a few examples where people came up with the best interpretations they can given the tools they had at the time. So, and again, these conceptualizations of illnesses have profound ethical implications because they affect how people are viewed as individuals who become ill, whether they're discriminated against, whether they receive treatment, what kinds of prevention messages are given, and so on. So one easy example is that of ulcers. Many of you may be aware of the history of how it was not realized at first that bacteria play a major part in creating peptic stomach ulcers, and it was actually it actually made some scientists disgusted to hear that this hypothesis that something like H. pylori, which is a very common bacteria, could be causing ulcers. Obviously, to a lot of people, it was really stress, and people could see in their own experience or their friends' or family's experience, correlations between eating a spicy food and then feeling like they were having a tummy ache, or feeling a lot of stress, and similarly feeling physical sensations, and yet there was eventually there was good evidence by Barry Marshall, who was who has been said to be reviled at first, that this bacteria H. pylori actually is playing a major role, and there still may be also some other factors at play. Tobacco may be at play, and perhaps stomach acid does play a role in addition with and there may be some other bacteria. But it turned out he was right, but it just was very counterintuitive to people. Just people were really focusing on what was obvious in their own experience. And just to remind everyone, I'm sure everybody in this room knows about the scientific method, but there's a problem in the scientific method that we can never quite overcome, and that's that we can't tell when something's really true. We can only approximate getting as close as we can to certainty that something's true. But this is a 2x2, and so this is reality. Well, how do we ever know what reality is, whether a hypothesis is true or not true? All we can do as researchers or consumers of research is look at the evidence and see what kind of conclusion we can derive from the evidence, whether the evidence supports a hypothesis or rejects a hypothesis. And then we have to make a judgment about whether that result is a correct decision, that we reject the null hypothesis, or that we support the hypothesis. And so that's just the nature of science. We're sort of stuck. It's, it makes it harder for us to resolve controversial illnesses because there's always gray areas, there's always limitations of studies, and so it makes it possible for even the experts to disagree with each other. So the ideal in the scientific process, just to again remind ourselves, is that researchers come up with an idea, they gather information, but in order to do that, they have to figure out a way to operationalize it, which means they have to get very specific about how they are measuring it. And then they interpret the results, compare the finding with their original idea. If the finding doesn't match the original idea, hopefully they change the idea, come up with another way to study the new idea, and so on. And so it's a circular process, ideally, until people feel pretty, that there's reasonable confidence that the answer's reached. I like this little bumper sticker. Ever stop to think and forget to start again? Well, sometimes that happens. Researchers don't always, entertain uncertainty for very long. When we have our own biases. There's reward structures for researchers to try to achieve confidence about a research question, and so on. And there's other reasons, and I'll try to touch upon the other reasons as well, that I think are preventing people from, doing enough thinking again to reach a really a full, feasible understanding of controversial infections that may be causing major health problems. And so part of my understanding is informed by Thomas Kuhn, who wrote The Structure of Scientific Revolutions. He said that people who include researchers tend to work within a paradigm which is a set of core ideas about a particular phenomena. And then that paradigm only focuses on what it considers important, and then right there you have a judgment call. It ignores what is not considered important within that paradigm. And it also assumes that only certain methods are appropriate for testing the ideas. And he coined the term normal science for what scientists normally do, which is, without even usually being aware of it, we work within a paradigm and we apply certain methods and we just ignore, we don't even think about other possibilities. But evidence does mount, people talk, patients sometimes inform doctors about things that sometimes change the way the doctors think. Patients' views sometimes reach researchers and inform researchers. Evidence starts accumulating in given areas, and I'll try to point out a little bit about how I think this happens with Lyme disease, and there starts being a lot of conflict and social tension among people who care about understanding a particular phenomenon, and in this case, an infectious disease or a disease that might be caused by an infection. And one of Kuhn's insights, not everyone agrees with them, but if you agree with this, this model, is that it's very difficult to change a paradigm. So a little bit of evidence is not going to make much of a difference. It really takes quite a bit of evidence. And then he says basically the progress in science tends to be stair steps. It takes a whole bunch of evidence, and then all of a sudden there's a jump to a different paradigm, and then a whole bunch of evidence, and then all of a sudden. He uses the Copernican revolution as a good example, where the astronomers who were trying to go along with the idea that the Earth was the center of the universe had to come up, they watched the stars very carefully and they mapped them, and they had to come up with these extremely convoluted, charts about how these stars were going around the Earth. They weren't very parsimonious, but they were trying to make sense out of their paradigm given the data. And so people can actually look at the data by discounting it or by twisting it, to support the old paradigm. Okay, so now I'm going to talk just quickly about some previously mysterious illnesses, which we came to understand, and so just say a little bit about the process. So the Black Plague, it was named to actually focus on the area around the Mediterranean, northern Africa, and the Middle East, as well as Europe, and it was one out of 3 major plagues in the world. And there's actually been numerous plagues in the last 2,000 years. It's still it's still around. It's caused by a bacteria, Y. pestis, which is carried by fleas that feed on rats and other warm-blooded animals. And what the thinking is, they don't know for sure, but they think the way that it got into Europe and the Middle East is that it was carried by fleas and furs. The fur traders, packed the furs in boxes, and the fleas were still alive in the furs, and that they, they traded them along the Silk Road. People were getting plague along the way, and they brought them all the way to Europe, and so it had a devastating result in estimated to be about 20 million deaths. And of course, back then, the institution that was extremely politically dominant in Europe was the Catholic Church. And so it really had, institutional hegemony in terms of explaining, some kind of major problem that society was affected by. And so the plague was explained as punishment by God of the sinners. But people were still turning to the church for help, and the public, couldn't help but realize that the priests themselves were unable to help people to prevent death or the spread of the disease. And the Catholic Church, at least at times, actually suggested that people get together and pray, which turned out not to be a good idea during the plague.
Bathing in urine, how did that work?
Yeah, bathing in urine. I'm not sure what. Well, there was this idea that was literally floating around miasmas. There was this idea that there were these essences that caused disease. Most people weren't thinking in terms of concrete germ theory, but thinking of bad air, bad water that was responsible for a lot of illness. And so they thought somehow purging to get the badness out of you, otherwise purging, bleeding, fumigating, cleaning up the air, it makes sense. Bathing in urine. I guess they thought that would kill it off. And prayer, because they believed that God ultimately had control. I just throw this in we're talking about the plague and put a little Far Side cartoon here. The blast up to now, the rhino was one of my prime suspects. So things weren't working very well. The word quarantine actually comes from the idea of the ships that during the plague were forced to stay off of the land, and they had to stay for, in some cases 30 days, sometimes 40 days. And it turned out that didn't stop the plague because the rats were able to just crawl along the ropes that were connecting the ships to the docks. Because the ships weren't just floating out in the sea, they were actually, for the most part, docked in the harbors. And so the plague just kept continuing, even though, people were being, quarantined on the ships. And another thing that happened was, and you can see where this seemed like a good idea because it was kind of obvious to people that if people spent time with other people, those people were more likely to get sick. People did, figure out that correlation. And so, to some extent, people were quarantined in their homes, and then that actually made it worse because the sick people in the homes were quarantined with the healthy people, and then the rats were still stuck in the homes, and so, then everybody got sick and people would sneak out to get food and stuff. So that didn't quite work. And there was somebody back then who was named Girolamo Fracastoro, I think, and he actually did come up with something that was as close to germ theory as was possible without microscopes. He said he thought there were seeds, some kind of like physical seeds of contagion that were causing some of these illnesses. But he didn't have microscopes, and the germ theory wasn't really developed at that time. But he actually was kind of onto something at that point, and so then. There was somebody named Easton who actually isolated the bacteria in 1894, far after the bubonic plague. And he used microscopes and he infected guinea pigs using a sample from a sailor's tumor and cleverly figured out that was the bacteria. But they still didn't know how it was, where was it coming from? That's not enough information to really know how to prevent it. Here's this bacteria that's causing the illness. So a very important piece that was then discovered was by Paul Lewis Simon, who in 1898 noticed that the sick rats did not groom as much as the healthy rats, and they had a lot more fleas on them. And so, they just weren't grooming, and so he actually did a bunch of experiments, and he nailed down, as much as we can in science, that the fleas were transmitting the bacteria and causing this plague. So that was really important. Let's see, I think I just went backwards. Oh, and previously, before they figured out what was causing it, people thought it was astrology. People thought it might be if you wore wigs or gloves, because there was a correlation between people who wore wigs and gloves and seemed to infect other people. And it was probably because they were trying to cover up the sores, because people who had the sores were obviously, discriminated against or, isolated. Oh, I'm sorry. I just jumped into syphilis. Okay, I'm talking about syphilis, not the plague. Okay, what I just said was about syphilis. Please correct that in the transcript that's written up from this talk. so when syphilis came, again, they didn't have microscopes and germ theory, and so people thought maybe it was due to astrology, because that was one of the perspectives being used to try to figure out, make sense out of interpretable phenomena, God's punishment for sexual excesses, and then the wearing of wigs and gloves, as I just said. And that got isolated in 1905, but there were still aspects of the conceptualization where people really disagreed that were fundamental to understanding this infectious disease, and that is how to prevent it. And so there were basically two different ways that people thought it could be done, and the dominant way was to come down hard on people and punish them. Is a very moralistic view. And so it was quite prominent in the United States in World War I, where prostitutes or women who were perceived to be prostitutes who lived near military bases were heavily quarantined. When men became infected with syphilis, they had their pay withheld, and the military actually refused to distribute condoms to the troops. They had condoms at the time, but they thought it would encourage, more, sexual promiscuity. And guess what? It didn't work. The rates of syphilis and other STDs stayed the same or increased during and after World War I. So that's in contrast to this other view, which some people would have argued earlier, but a more non-judgmental view, which actually turned out to work. It was part of, so it was that it involved providing condoms, educating people, giving antibiotics, and there was a dramatic fall once those policies were put in place. From from 1940, dropping from 72 per 100,000 to in 2004 to 2.7. So a dramatic fall that was associated. So one thing that this tells us is that behavioral scientists actually have a really important role to play in dealing with infectious disease. So the concept of an illness is not just relevant to scholars of the hard sciences. The behavioral scientists, the public health specialists, people who understand how to influence human behavior are also have importance not just in what actions they can take, but actually conceptualizing what actions need to be taken. So that's part of the understanding of infectious disease. Another Far Side cartoon. Okay, listen up. The cops are closing in on this place, so here's our new hideout, 455 Elm Street. Let's all say it together about 100 times so there'll be no screw-ups. And so this is just to make the point that when you say something over and over, when you hear it over and over and over, it's very easy for all of us to just not question it, because it just seems self-evident. Well, with the advent of AIDS, this kind of happened, I think. It's actually, Lynn Johnson wrote something up on this, that at the beginning, the people who were observed to have the symptoms were primarily gay men and injecting drug users. And it really wasn't conceived of as an illness of women. I think you said 4 years, that something like for 4 years, after many people were getting sick, women were getting sick, and women who were getting sick with AIDS were actually denied disability while they were, very, very ill. And no research was being done with women on who had AIDS. So, it was possibly, you could see this possibly as a fluke that, one group was showing signs of the illness, or two groups, but primarily identified with men, and so women were just, not even part of the, it wasn't, not even on the radar screen as possible, victims of this infection. Another interesting thing about HIV was that it was discovered by Luc Montagnier, possibly by Robert Gallo as well. There's some controversy about that, but Luc Montagnier's group actually got the Nobel Prize for discovering the virus HIV that causes AIDS. And interestingly, he's being criticized now for his research on Lyme disease and his research on homeopathic medicine. He's been funded, he actually has an institute built for him in China recently. He's moved from France, where they won't fund older researchers, to a huge institute in his name in China to do research on these very controversial phenomena. And he said, look, people said that I should stop doing research to see if AIDS was caused by a virus. I think I'm on the right path. I'm going to keep on going. So in order to change conceptualizations of illness, we need some people who have really deviant views, who are willing to, follow their, listen to their own drum, or, however you want to, describe that, and go against the norm. And sometimes they're the ones who have the great ideas, sometimes not. Okay. Well, so there's an organization that's actually heavily involved in the dispute on Lyme disease. I want to tell you a little bit about in relation to HIV. And again, I actually learned this from something that Lorraine Johnson wrote, that with Raphael Stricker, that for over a decade after the AIDS crisis began to be visible to Americans, the society that really should have been dealing with this as part of its agenda, the Infectious Diseases Society of America, as it was a very, very large professional organization in the United States dedicated to infectious diseases, really did very little to focus on this illness. They really did not intervene in the early stages of the AIDS crisis in the United States. For about over a decade, they kind of were ignoring it. And then what happened, and there might be a lesson here, is that another organization arose. And there may be a lesson here because the other organization, the American Academy of HIV Medicine, a smaller organization, was formed to really address the needs of patients with HIV disease and their caregiver and the needs of their caregivers, pushing for greater access to care. And what happened was, it looks like the IDSA got influenced by this other organization taking this on, and there's probably more to the story that Lorraine could tell you. And so they did take it on, and now they're taking it on, very fruitfully, and really, with appropriate, concern and focus. And so now both the organizations are existing in parallel. And then. And then I just looked at this history of the research on cancer, because there's some mounting studies now suggesting that at least some cancers may be caused by, or at least partly caused by, infectious diseases, bacteria and viruses, and that was an idea that was around earlier. But then there was a shift away from thinking about infectious diseases as a possible, possibly being linked to cancer. People thought that we pretty much had it all figured out about infectious diseases. At least some people did. The U.S. Surgeon General, Stewart, referred to closing the book on infectious diseases, meaning basically we figured out infectious diseases. We kind of know what all the main infectious diseases are. And by the way, I recently heard a talk by, I think his name's Ira Lipkin, a renowned virologist, who said that we don't even know what over 99% of the viruses are. We don't have any tests for them. We haven't named them. We don't even know what they are. So there's obviously a lot more potential for other infectious diseases at this point. The same thing's true about bacteria. But in the 1960s and 70s, there was support for the idea that cancer could cause that infectious disease could cause cancer. But and there was a war on cancer. Some of you may remember that President Nixon pretty amply supported with funding for research. But unfortunately, according to Ewald, there were two camps. And so, this is this is something we need to learn from. There were two camps. And so one camp thought it's only infectious diseases causing cancer. And the other camp thought it's these other things, environmental factors and or genetic factors. And the camps weren't really talking to each other. They weren't really collaborating and trying. They weren't saying, well, maybe it's both. Maybe we need to work together and see how much of it is each, for certain kinds of cancers. And so in the 1980s and 90s, unfortunately, the funding for cancer wasn't as great, and it became fashionable to really focus on, partly because of some of the technological changes and the greater understanding about genetics and so on. It became fashionable for cancer researchers to really focus on genetic and non-infectious environmental factors like air pollution and smoking as possible causes of cancer and to ignore infectious causation. And now there is emerging evidence. So, again, there's this history where people's thinking really affected the science that was done and the science that wasn't done. and Paul Ewald feels that this is really a tragedy, that countless thousands of people he feels have died as a result of not having the infectious disease component that caused their cancer in the first place to be identified. Because the idea is maybe if you caught these, if we found out that some of these infections can lead to cancer, maybe we can screen more carefully for them, treat them, and prevent cancer down the road. And another problem he's pointing out is that there's an organizational structure problem. And that, with organizational boundaries and what they consider to be their mission statement. So the Environmental Protection Agency has really been focusing on toxins that might be causing cancer, like air pollution and water pollution. And then there's the CDC, which has really been focusing on its targets, separately on the infectious targets, separately from the EPA. And so, that might be also getting in the way of people, working together and collaborating and doing much better science. It may be that, for example, the infectious diseases are more likely to take hold when there's toxins in the person's body, but, there may be, synergistic kinds of relationships that we're missing because we're not doing our science in the best way. Okay, brings me to Lyme disease. This is so controversial. How many of you, before you came in this room, already knew this is an extremely controversial topic? Not everybody. Okay, well, good, because that's for those of you who haven't heard about it. I would really like to tell you a little bit about it. It is the most common vector-borne illness in the United States. It's transmitted, it's often along with co-infections. The co-infections can be just as serious or even worse. And there may be co-infections we haven't identified with. Remember, we don't know what all the bacteria and all the viruses are yet. We only know a few of them. And so there may be a lot of illnesses being caused by things that we haven't even identified with. And a lot of people call ticks dirty needles. They carry a lot of microbes. And so people who get Lyme disease from a tick, are also at risk from getting other things, or they could get the other things and not get the Lyme disease.
What is a vector-borne?
I think it's spiders and insects. Do I have that right? Yes. Yes, it's very funny. What's that? Yeah, it is the ticks. Yeah, it is the ticks that are causing it. But the more generic term, vector-borne, is spiders and insects. And it's interesting that I hadn't realized this before, but ticks are actually 8-legged. So technically they're arthropods, I think they call it. And there's a lot of diseases being communicated by vectors. West Nile virus, for example. The other things that we're very, very concerned about in the United States. And so you're absolutely right. The Lyme disease is carried by the infections from the black-legged ticks. The typical symptoms include, in the short run, the typical symptoms include fever, headache, fatigue, and there's a rash, which is controversial because we don't know if it's always there. We have some evidence that it's not always there. Typically a bullseye rash called an EM rash. And then this is all the acute phase. So oftentimes people get bitten by a tick, they develop these flu-like symptoms, and then nothing happens, and they think they're fine. But there is evidence that I think is pretty common evidence that at least in some percentage of people, we don't know what percent exactly, infection can spread to the joints, to the heart, to the nervous system, including the brain, and to things, other parts of the body, the thyroid, and other, the sexual organs, the eyes, other parts of the body. So this can be a very systemic illness. And it's supposed to be diagnosed based on symptoms, physical findings, such as the doctor being able to see your rash, and the possibility of exposure to infected ticks. For example, if you live in the northeast of the United States, you obviously are much more likely to be exposed to infected ticks because there's so many people that are clearly ill with Lyme disease in the northeast, at least. But there's a controversy about whether you can also get Lyme disease throughout the whole United States. That's one of the controversies about how prevalent this is. And laboratory testing by the CDC is considered helpful, especially in the later stages of the disease. The laboratory testing tends not to show up people being positive right after the tick is bitten. You can, if you're bitten by a tick and you're worried about it, you could actually put it in a baggie and send it to a lab and get it tested. So that's one way of dealing with it in the short run. Now I'm just sneaking in some data of mine, because remember in that last slide it said the symptoms that you have can help you determine can help the doctor determine whether he or she thinks you have Lyme disease. Well, I've done a study recently funded by a number of organizations. Actually, Lorraine Johnson's is one of them, LymeDisease.org. To look at 1,056 medical records of people who were diagnosed in Northern California clinic with Lyme disease, and to look at 132 symptoms to see whether we could find any kind of organization in these symptoms. Because if the doctor is supposed to look for symptoms, if there's something like 132 symptoms, how can the doctor make any sense out of them? And so we actually we analyzed medical records on these 132 symptoms, and we found 4 underlying patterns, which we're very pleased to find because it was a statistically very tight solution, and the patterns fell very neatly into 4 different kinds. I'll just tell you really quickly. One that was a very general, less symptomatic pattern. One that was mostly musculoskeletal joint pain and swelling. One that was both of those plus neurological problems. And then the 4th, which really got into eye problems, heart problems, reproductive system problems, urinary gastroenterological problems, and psychiatric problems. And that's that bottom. Well, the way to read this heat map is, if it's red, it means almost, these are bands of people, about 250 people in each band, and so this band, so when you see the color red, it means almost everybody in that band reported the symptom. And so here's the musculoskeletal symptoms, and you can see all these people in this band, and then a lot of people in this band, and a lot of people in that band. And then the darker colors means very few people in that cluster reported symptoms. So one interesting thing is not everybody's saying that they have all the symptoms, which goes against what some people are worried about, is these patients who are coming to us thinking they have Lyme disease, they think they have everything. And that's not the case in our data. And there's actually a part 2 of this, which I'll just show real quickly, which is, this is the other half. We couldn't get it all in one slide. And these are the neurological symptoms. So you can see in this 4th band, the neurological symptoms are highly prevalent. And they're pretty serious neurological problems that a lot of people diagnosed with Lyme disease report. And interestingly, a number of them previously had been diagnosed with MS, ALS, Parkinson's, rheumatoid arthritis, and other serious illnesses. And so that raises all kinds of questions too. A lot of them report that they're getting much better on antibiotics for these other kinds of illnesses. So this is like raising all these questions. What does this mean? So it shows you how complex this illness is. What we did is we accepted a community-based doctor's view of who met the diagnostic criteria rather than going with the official view. And so this is what we're finding. In the Bay Area, there's a lot of people sick. We're either not finding answers to why they're so sick, or they're finding a doctor that tells them they have Lyme disease. And there's many doctors who have been trained that there's no such thing as Lyme disease in California, or there's virtually no Lyme disease in California, and that some people refer to these patients as having internet-itis, that they're spending too much time thinking about their symptoms. Okay. So there is I think I got my slides out of order. Here's the debate. Two competing views of Lyme disease. And there's two competing organizations that are at the forefront. There's other organizations, but I would say that these are the two organizations that are identified most with the two views. One is the Infectious Diseases Society of America, the IDSA. They believe, they write it in their guidelines that, and in their, they imply it in their articles. You can find lots of publications where you can see that they believe that this is easy to diagnose, it's easy to treat. It's very implausible that people can that most people are going to get a chronic form of it, and so that has treatment implications, because if it's extremely unlikely that people are going to get it in the first place, then you're not going to see it. The tests aren't very good, and so you might not even give a person a test if you don't think it's worth it. If it's easy to treat, then the guidelines recommend 2 to 4 weeks of antibiotic therapy. And so the insurance companies pretty much abide by that, and the HMOs so they've really had a huge influence on policy, and then you cannot get paid, you cannot get third-party reimbursement beyond the 4 weeks. So this has very major treatment economic implications for people, as well as treatment implications. So then the other view is all the opposite. In fact, the International Lyme and Associated Disease Society, ILADS, says that this illness is often hard to diagnose, often hard to treat, and it's common. We don't really know how common. They don't. Some people say it's maybe 10 to 20% of people who get Lyme disease go on to develop a very chronic form. We don't really know, because we don't have the test in the first place that everybody agrees is good, that we can then say, well, of those testing positive, how many people are getting this long-term chronic form. And then I'll just go back. And so because of this heated debate, partly because of it, the Institute of Medicine of the National Academies was requested by NIH to hold a workshop about the state of the science regarding Lyme disease and other tick-borne illnesses. And there were some diverse views presented. I think there was somewhat of an imbalance, but on one side, but there was a diversity in views presented on the very nature of Lyme disease, showing the lack of consensus. And the IOM responded to the data, really trying to take in what people with both different perspectives were saying by calling for more research, realizing that the research base just wasn't adequate for resolving the differences in views.
Would there not be ability to solve the riddle simply by studying the bacteriology of chronic disease if the second group, ILADS, is correct that the infection persists?
Well, it's context matters, and so you're right. It's really, really important to understand Borrelia burgdorferi that causes the illness in the United States. It's really important. But without putting it in the context of human beings, to see what happens, interacting with the immune system, we need that extra information, and then to know how it interacts with antibiotics or other kinds of treatment. So, so you're right, that's a really important part of the science. And a lot of work has been done to try to understand the Borrelia, try to understand it on a molecular basis, and to try to look for subtypes, genetic subtypes, and there's some really exciting research still being done in that area. It's a very complex bacteria, and so there's been an awful lot to learn about it. So there's one aspect that seems to be contributing to the conflict, or at least from the ILAD side, has been that there's been, and people beyond the ILADS organization, is that there were some really classic conflicts of interest in, by some of the IDSA panelists who created the guidelines in the first place about how to diagnose and treat Lyme disease and the other tick-borne illnesses. They own stocks in companies that had produce the diagnoses for the test, or other kinds of classic conflicts of interest. And so that was brought to the attention of the State Attorney General of Connecticut, who launched an investigation that really nailed down what the conflicts of interest were on the panelists who had been serving on the original panel. And so the IDSA formed a new panel with people who didn't seem to have any conflicts of interest. And what was very interesting was, actually, Lorraine Johnson was one of the people who testified before the hearings. There were a tremendous number of pages submitted by people on the ILAD side to the IDSA refuting the standing guidelines. There were over 300 peer-reviewed articles that they cited that they felt really undermined some of the guidelines. And despite that, the panel really voted to stick to its original guidelines. So you can kind of try to read into that. We don't know for sure, but there's conflict of interest, and so in psychology we have a concept of self-serving bias. You don't see yourself having a self-serving bias. It's invisible to you. You just, for some reason, you just see something a certain way, and it happens to benefit you. Or how much it makes you wonder how much of this is professional identity. People really feeling an affiliation with the IDSA, or their own identity of what they believe is right, in treating these illnesses. Oh yes, thank you. Yeah.
I guess I'm misunderstanding some of this. If the person is evincing some of these symptoms, the rash, the joint pains, etc., can't they just draw some blood and either look for the bacteria or the toxins that the bacteria creates? Or what's the mystery?
Yeah, you would think that. See, and I think we'd all think that. We don't know for sure, but there's a number of reasons why we think that the bacteria are hiding. That they take other. They burrow into the tissue and leave the peripheral blood, so that they're not necessarily in the blood. And for example, if you had spirochetes in your heart or your brain, you really wouldn't want to have an autopsy while you're still alive of those parts of your body. There's evidence that the spirochetes seem to hide when people get on antibiotics. They may form a hard shell around them and not really be detectable. Yeah.
So they are a spirochete?
They are a spirochete, and they're very complex, and that's part of why they can create so many different symptoms. They have this corkscrew shape, and they can burrow into different parts of the body. And there's some actually, Karen Newell at Texas A&M sent me a video showing with a mouse model the spirochetes for Lyme disease burrowing into a mouse's brain. In real time, you can see she and her colleagues have figured out how it actually can get into the brain, past the blood-brain barrier. But in addition to that, the immune system in the brain can react to information that comes to it without necessarily having the microbes enter the brain. The brain can react to the information that there's an infection in another part of the body by setting up an inflammatory response, potentially attacking its own neurons. Thinking that there's there's a lot of ideas about why a person can be very ill and still the tests aren't picking up on the spirochetes directly. Most of the test that's actually used most commonly is looking for the antibodies which is the immune response to the spirochetes, rather than directly picking up on the spirochetes.
Is the IDSA primarily academic scientists?
Yes, yeah, it's a. I don't know if there's a lot of Lorraine.
Primarily academic scientists and researchers.
Yeah, and the ILADS.
It's very, very hard to understand your conclusion.
Yes, I appreciate that. I appreciate that. And so let me say about the ILADS organization. So I think sometimes important ideas come from the ground up and not necessarily from the top down. And or at least we have to consider them. And so the ILADS organization is comprised largely of doctors and other health practitioners who have huge patient loads of people who they think have Lyme disease and some of these other tick-borne illnesses. They're just inundated with patients. They have, if you go into one of their offices, you'll see wheelchairs and, people who look like they're really, really sick. And there, anecdotally, a lot of people are getting far, far better on antibiotics. But the research hasn't been funded to look at longer-term antibiotics. Beyond I think the longest one is 90 days or something. But what the clinicians who serve the Lyme disease patients who seem to have the chronic form say, like one of them is named Sam Donta, he said from his experience, it looks like people need maybe 12 to 18 months of antibiotic therapy, which is far, far more than the 2 to 4 weeks that the IDSA recommends. So there's people who are practicing who literally, some of them have thousands of patients. People are flying from other states because there's nobody practicing in their state that seems to be helping people like themselves. And then you have scientists who are having very little contact with patients for the most part, who have these ideas that they're testing. And so it seems like there's some potential here to get these two groups together, and that's part of what I want to finish. And I know I'm running out of time, so I will move quickly here to make that point. And so I just want to make this point that there's a recent article that was published in The Lancet by people who support the IDSA view. And even though the article is kind of implying that people on the ILAD side don't care about the science, there's actually, I think, a lot of evidence to the contrary. If you look at the testimony that the ILAD's advocates gave at the hearings, and if you look at the publications, they're heavily citing the peer-reviewed research. Most of them are in private practice, so they're not funded to do the research themselves. And what's very interesting about the IDSA in this context is that their own studies as a whole are actually not meeting the criteria that they know would be the ideal. There was a very recent publication by Kahn and Associates in 2010 that analyzed all the IDSA guidelines across diseases between March 1994 and July 2009, and they found the vast majority of the guidelines were based on pretty weak evidence, expert opinion, or non-randomized observational trials. Daniel Cameron, who's a former ILADS president, with the other view, himself uses a lot of empirical evidence in his writing, and he's pointed out how this is extreme. I just want to come back to what an extreme burden this is. That that in the publications that are already in the literature, that using randomized clinical trials, the evidence is consistently that the quality of life for people who have this, people who've had Lyme disease, whether they still are infected or not is a question, but people who've had Lyme disease and been treated for it largely have a quality of life comparable to persons with other very serious illnesses such as congestive heart failure, and clearly worse than people's quality of life in the general population. So it seems, this is to build the case. We need more research. This is really important. This is causing suffering. This is causing a lot of conflict. And I just want to mention there's stigma involved in doing research on this topic. Stephen Barthold came to Stanford University a few months ago to give a talk about the persistence of the spirochetes after aggressive antibiotic therapy in animal models, and he said that just to do research on this topic is stigmatizing, and that's why he thinks that so few people are doing research. I myself have been ridiculed on a blog by a nationally known figure as a fake researcher at a real university just for the research. I hadn't even published the findings yet. and just for asking the questions. And I've been told by a senior person, that, why, or asked, why are you doing this? Why are you doing this? This doesn't make sense. Why would you do this? We already know everything there is to know about Lyme disease, which is a bizarre thing to say about any topic in an academic institution. But I cannot complain because the patients that I'm talking to, I've recruited 90 patients for an ongoing study who meet criteria for chronic Lyme disease, and they say things like many doctors and healthcare providers have been rude, short, condescending, and unsupportive. The urinary tract infections, UTIs, were intense. I would bleed clots in my urine. They were very debilitating. But when I was in a gown, the doctor said, women like you are a pain in the ass. It was humiliating. And I'm hearing these stories over and over and over again about how people are being mistreated when they go to emergency rooms and so on. So, I mean, again, clearly there's the need for research. The IOM, is calling for research. So what can we do? What's going on here? Why, what's the problem? Another practical implication of why we need to do this research is that by not knowing, we don't even know how to prevent it. So if it turns out it is sexually preventable, sexually transmissible, we really need to know that, because then the prevention messages need to get out there. Anecdotally, I mean, a lot of people who think they got it from their sexual partner, but there's no research going on. So the IDSA says it's not sexually transmitted. The CDC says it's not sexually transmitted. But what they really mean is there's no evidence, meaning there's no evidence that there's no evidence. There's no positive evidence, but there's no negative evidence either. The research just isn't there.
What was the previous recommendation of the IOM?
Oh, just how important it is to address the significant gaps in our understanding. That this is an area where research is so badly needed. And what do you think, 5 minutes? Yeah, I'll try to. Okay, so let me skip this and I just, I won't dwell on this, but I did a little analysis here of what happens if one side's wrong, about something, and but everybody believes it. What if one side's right about something and everybody believes it? What about the other side? And then what are the consequences? And all the consequences have ethical implications if you look at them. Like, it's good to avoid unnecessary side effects of antibiotics, but on the other hand, it's not good if you need antibiotics and you're not getting them, and so on. And so, so this is just to sort of point out that, part of the problem, I think, is that we don't have the technology in place, although there's some very exciting technological breakthroughs on the horizon and things that have actually happened that aren't quite out in the public yet, that are probably going to clear up, hopefully help play a big part in clearing this up. But, we're human, and so even if our technology gets better, we still have our own human foibles, our human biases and so on that we have to deal with, and our political realities. So I did try to take Christy Monroe's moral theory of moral choice. It's just my own rough attempt to try to highlight what I see as some of her key ideas. And I loved her focus on, looking at a person's ethical perspective and how that, interacts with the environment, and how important it is to see options, to have, you used the word menu of options, that having the menu of options that could help, resolve something could really make the difference. And if your menu of options is too small, then it will take you to a different place. Or it might have some inappropriate things in it that will also take you to the wrong place. Let's see. And so I think by taking your theory of moral choice, we can actually think about some of these factors that I've been mentioning, political factors, organizational, psychological factors, and put those within the context of how people try to make themselves think more ethically in order to do science, to practice better medicine, to practice better public health prevention efforts. And you used the term cognitive stretching, which I also love, which you said is drawn from child development, but it's really, and it's constrained by people wanting to be too certain, but the idea is really that despite these filters such as a person's identity and environmental factors that you define certain ways, you can change, you can expand the number of ways that you can see something. And So, Monroe relates this to expanding and constraining the moral imagination, potentially creating more options beyond existing cultural norms, and also expanding the menu of possible responses to, reduce others' suffering. So what can we do? So here's some concrete suggestions. We can fund interdisciplinary research, we can, I think the guidelines are really important. I think Elaine's about to talk about that. We can listen more to the patients and give patients more say about decisions where the science is muddy. And we can try to change the culture of medicine so that it's okay to admit that we don't know everything about certain areas of medicine. But there's another approach that, I'm not saying those things aren't valuable, I think they're very valuable, but there's an additional approach I just want to conclude with, which is to intentionally push the boundaries of thinking. And one way of doing this would be to take people, either creating people who have very divergent views, or to take work groups that already exist, and help people value diversity and conflict in their viewpoints. I just heard a talk recently by our Associate Dean at Stanford, David Stevenson. He's actually writing something up on this. He's got a concept that I've never heard of before, transdisciplinary. And so he differentiates it from multidisciplinary and interdisciplinary. So let me just briefly say what he sees that those concepts is referring to. So he sees multidisciplinary as good, but it's parallel play. It's a bunch of people, they're all sort of doing their thing. They might know a little bit about what each other's doing, but not really consciously trying to integrate their ideas together. And then interdisciplinary work involves a more conscious attempt for people to try to aggregate their ideas, but people still may not really internalize the totality of the aggregation. People are still kind of focusing on their part of it. And then you should probably see where this is going. Transdisciplinary really refers to an overall synthesis where ultimately people buy into the entire model, and people have to stretch themselves by learning something more about what other people's disciplines, concepts are, and methodologies, and vice versa. Not that everybody becomes an expert on everything, but that people are able to be part of teams that can develop a unified perspective on a given research problem. And I want to throw you another tool here, because I think this is also very exciting. We also had a workshop at Stanford recently, I think it was February, by Michelle Bennett and Howard Gadlin. It was an NIH workshop that I think they're doing elsewhere. You might be able to have them come here if you'd like. It was all in collaboration and team science. What they've done is they studied intensively 5 highly successful NIH-based research teams. They called them the integrated research team. They said that these highly successful, very productive, very creative teams, they have an openness of ideas and a willingness to challenge each other. I'm going to say a little bit more about that, and then I'm going to wrap up here. And so one of the things they do is and you see this is still going to create conflict, is they try to help people have a sense of ownership and responsibility. That means people are going to be very invested in the process. Well, that often, that often creates a lot of conflict in groups, because the people who are less invested obviously are less likely to get things under their skin. And they look out for junior people as well as senior people by trying to help junior team members be able to carve out aspects of the overall work that they can kind of spin off and take on for their own. But the team also, these highly successful teams develop an overall identity for taking responsibility and being accountable for failures as well as successes. Now, what they've done is they've drawn from Bruce Tuckman's model, which I guess was originally published in 1965, for team development. And they say that there's a cycle of processes, stages that happen in a really good team. They call them forming, storming, norming, and performing, and then adjourning or transforming. So forming is, the group just gets together, but there's this really critical thing that happens right away when you get people with really diverse views together, and they call it storming. And storming involves confronting threats to collaboration. And of course, that's going to come partly from power and status, people's desire for autonomy, people's distrust of each other is critical, people who just are inattentive and who aren't really cohesively drawn into the group. And they say, Bennett and Gavin say, that storming must occur in order for a group to really function. Conflict is actually essential, they say, and they say you can teach these stages to people. You can teach them, so a person could say, hey, I think we're storming, when things start getting hot, and you can do, they actually have a number of practical suggestions. I don't have time or, to go over the details, but they, for example, they say that you can have prenuptials for scientists, and they have a list of things to include in your prenups when you're forming a collaboration. And so I conclude with a question: how can people and groups in conflict about ideas, such as about the nature of Lyme disease and how to address it, develop common understandings that embody our ethical principles of truth, autonomy, justice, and benevolence? I was close to a breakthrough when the grant money ran out. Okay, thank you so much for your attention. Really appreciate it.
Time for a few remarks by Lorraine Johnson. Lorraine is the Chief Executive Officer of LymeDisease.org and is a legal advocate for better evidence. Keep it short. I would be very short.
I want to thank everybody for coming tonight, and I'm going to talk to you from the perspective of a patient advocate in Lyme disease, and also as somebody who's on the steering committee for Consumers United for Evidence-Based Medicine, which is one of the organizations in the United States that's bringing together coalitions of patients to start forming the patient's voice in evidence-based medicine, which I think is a really important thing for us to be doing right now on the cusp of healthcare reform. And so I wanted to start off by just talking about the concept of why do we have so many controversies today? It seems that there's a controversy almost in many scientific areas. So some of them that come to mind are global warming, frac mining, genetically modified foods right now, for instance, are big areas where there are some controversies. And of course, there's controversies in medicine, and this is a list of 25 conditions where there are conflicting medical guidelines. This was put together by the National Guideline Clearinghouse. And so when you see this, the question is, why do we have controversies? If science is so certain, what is it that people are disagreeing about? And if even the experts are disagreeing, what's the topic of the disagreement? And we have controversies also in disease spectrum. And these are some of the ones I just went out and researched and pulled up some of these. But historically, there were a lot of controversies involving HIV, and Lyme disease is obviously a very hot topic. Interestingly enough, colorectal cancer is apparently a very contentious area also at the moment, which surprised me a bit. So when we're talking about a disease and we're talking about controversy in the disease, one of the questions is really, what are we talking about? And you can have a nice normal distribution and have samples that are drawn, like say the blue sample or the gold sample, that are really hugging close to the mean and may be representative of your population. But a lot of times the samples that are drawn in clinical research will be more like sample 2, the blue sample, or sample 4, the pink sample. And so you get a highly selected population that's being looked at. Let me give you an example of what I'm talking about. In chronic Lyme disease, the largest clinical trial that was done involved 57 people in the treatment arm. And we went out and we did a survey sample and drew in 2,400 people. And one of the things that was really clear about the clinical trial was that everybody in the clinical trial had received early diagnosis and treatment. When we went out and we looked at the respondents to our survey, we asked how many had been diagnosed early, and only 16% had been. So, literally, you're talking about different sample populations. And when patients and treating physicians talk with the researchers, we're really talking apples and oranges, and will be until the spectrum of the disease has been more clearly defined.
But what was the criteria for entrance into the survey of chronic disease?
Well, it was self-reporting, of course, but it was you had to have been diagnosed with Lyme disease clinically, and we actually limited the sample population. We had a broad sample, but we decided that we wanted to make sure that we were dealing, as much apples to apples as we could be. So we took the two-tiered blood test, and the other blood test required laboratory confirmation. And interestingly, we compared the two groups, the groups that didn't have a laboratory confirmation and the groups that did. There wasn't a big difference. The only difference was it took longer to diagnose.
That was going to be the question.
Yeah, well, it's a good question. So, research is the tip of the iceberg, and, the base of the pyramid may well be the patients with the disease. And the designs of research are very different from the designs of treating and diagnosing patients. When you're dealing, make sure that you're diagnosing the broad range of patients so that those who can get better do. So when we have, a lot of controversy, evidence, evidence can go so far. A lot of times in science, there's a lot of scientific uncertainty. And then you have beliefs and you have actions. And actions would be, what do you do in the face of scientific uncertainty? Do you intervene and provide diagnosis and treatment, or do you decide that you want to wait and see? And the interests of patients and the interests of researchers in those two areas in particular may conflict, because the researcher may be more comfortable with waiting and seeing and letting a scientific base develop, and the patient may be very ill and requiring treatment. So, part of the concept is, who's an expert, in these types of discussions. Not the discussion about what the science is, but the discussion about where the science ends and when we get involved in public policy determinations. Who has authority, who's represented, and who's accountable, and who bears the consequences. So I'm going to stop with a slide that's this is a slogan that was from 1988. It was the AIDS activists, what they did a demonstration at Harvard, and they said, we're here to show defiance for what Harvard calls good science. And what's interesting about this is, of course, the AIDS activists actually became highly articulate, good research partners. I mean, they ended up transforming a lot of the research agenda and the way the science was done so that it became much more responsive to their needs. And today the slogan would be nothing about us without us. And I think both of these slogans, what they're getting at is the concept of participatory democracy and where is the role of the patient when you're dealing with areas of scientific uncertainty and you're making public policy decisions. So I want to conclude by saying that the Institute of Medicine has recently issued a report that's on creating trustworthy guidelines. And one of the things that they have called upon guideline developers to do is to have patients involved when they're forming the questions and when they first have their drafts out so that there can be comments on it. And I think the concept is to start shifting the paradigm a bit more so that guidelines will be more responsive to patients' needs, and so that patients can actually have a voice in the process. And with that, I would like to thank you for your time. Thank you.
I'll open the floor for questions. My question would first be to Lorraine. Do you think this is very likely? Yes. This is going to happen? That we're going to change the paradigm?
Well, change the paradigm. Well, changing the paradigm is going to take a long time. I think it's going to take a lot of scientific research. There is some really good research going on. I mean, interestingly, there was a study that came out this year that was by Monica Embers and Bartol, and they had taken non-human primates and they had inoculated them with the infection, and then they had treated them very aggressively with antibiotics. And because they were doing with an animal model, they had the luxury of actually, at necropsy, doing a lot of tissue samples. And they were able to demonstrate persistent infection. I think it was in like 75% of the monkeys that were treated. And at the same time, this was actually kind of a brilliant study. At the same time, they were testing the serum of the monkeys for antibodies, and they found all of the monkeys were testing negative in the antibodies. And this was because they actually found the spirochetes. They found the presence of the actual bacteria, but they weren't able to detect it in the antibodies. So some really interesting research is being done, but I think we need a lot more to get some change in the paradigm.
Could you just identify yourself so everybody knows who you are?
Thank you. I'm Delio Ogunseto. I'm in the program in public health here at UC Irvine. And thank you for fascinating presentations. It's too bad that Alan Babo is not here tonight, because he worked with Willie to develop the idea that this disease is linked to bug diphtheria. And he also has the patent on the vaccine for preventing Lyme disease infection. And he still does research on this. And I know that he wrote a book in 1996 about the causes and the controversies of Lyme disease. But that was a long time ago when the diagnosis was based on the antibody detection. The sensitivity of current methods seems to have gone way beyond that, but I can understand the difference between recent infection and chronic infections. I don't know that they still use antibody detection for chronic infection that's sensitive to antibiotics, because the organism will be killed if antibiotics get to it. So I'm wondering if the controversy really is not about the germ theory of the disease, but about the symptoms, as you identified as chronic fatigue syndrome, which was what the descriptions were before they discovered the bacterium. And so it's a very vague, just like we had with the HIV, a very vague group of symptoms that may have multiple causes. And I'm wondering if you could say a little bit about this framing of the disease as chronic fatigue syndrome versus chronic Lyme disease, which may be at the root of the differences between the two groups. This one is curable. This other chronic fatigue, we have no idea what the causes are.
There's somebody at Stanford focusing on chronic fatigue specifically.
Yeah.
Who himself is not really focusing on chronic Lyme disease. Jose Montoya is his name, and he's an infectious disease doctor. He's also done HIV research in the past, and he has some evidence for some viruses that may be involved in chronic fatigue syndrome, and actually has used antivirals with some of his patients, and I believe he's published a study or two on that. And so he's focused on it, where you're focused on obviously is going to give you different information. And so you're right that both illnesses have fatigue as a major core component. That's right. And they also have some symptoms in common with some other syndromes, Gulf War illness, which also, these illnesses all have fatigue, joint pain, neurological impairment, sometimes depression, and joint swelling, muscle ache. All these illnesses all have, and then some of the same problems, difficulties concentrating and memory problems and so on. So, we don't. So one way of thinking about it, I don't know. I'm open about this, but one way of thinking about it, I think there are a lot of people who are genuinely sick, who are not getting, diagnoses that are leading to, treatment that's helping them to get well. And so there is a problem before us, and so, one possibility is that, as you say, there's multiple things that cause maybe some sort of similar patterns. And we don't know, the body has certain pathways. Bruce McEwen has a theory of allostatic load by which various kinds of stresses on the body can lead to, he identifies, I think, 4 different pathways that the accumulation of stress can cause malfunction in the body. So maybe there are some more general.
I guess maybe the real issue is to just call things different names.
Yeah, it might be. Might be. There was a study by a woman named Carnes that took a look at chronic fatigue and Lyme and also fibromyalgia. And she did a meta-analysis, and she found that there were distinguishing features between them. So, but the symptoms do overlap.
And Brian Fallon's group did what was it, the proteins different in chronic fatigue, and maybe it was the proteins that were different in chronic fatigue versus Lyme disease versus. Yeah, I think that one was a co-author. Yes. So that's right. There are so you can kind of look at it kind of like as kind of sort of squinting your eyes and say, well, there's these patterns that look a lot alike, and then you can also find some evidence that there's some differences. And I wanted to say that I did have an opportunity to meet with Alan Barlow today, and we had a great conversation. And he actually gave me some great ideas for research. And we talked about bringing people together from IDSA and IRIS.
I think that would help.
Yeah.
One of the things we talked about afterwards was that they're trying to set up a center to study Lyme disease at Stanford, and we suggested you could do some collaborative work with the Southern California.
Yeah, our dean's doing something I think is very novel. He is, we have some potential funders who are very interested in trying to bridge the diverse views. And so he's holding a think tank in July to bring together people who totally disagree with each other, but amiably. He knows everybody, one of the people who's invited, and it's just some Stanford faculty. And we're going to be talking about possibly involving people from creating something that will involve people from outside of Stanford.
Thank you.
Ron has a question.
Johnson, I was intrigued by your description that the antibodies were not present. I'm not clear whether they disappeared or whether they weren't present from the beginning in the animals who continued to have bacteria in the tissue.
Yeah, this study is a really fascinating study. What they did was, after they inoculated the animals, they did it was a C6 antibody test. And they did it they were using like 4 or 5 months for what they considered chronic infection. And all of
And there you immediately have the confidence.
Well, that's part of it. And the other thing is you can't do direct testing. For the humans, all you can do is ask them what their symptoms. They were using, SF36 tests, beginning and end points. And, they couldn't obviously go in and do tissue biopsies. They could do a PCR, but this is an organism that's known to be sparse in the blood, so there wasn't going to be a high yield on that. And the antibody tests are, they weren't very good at doing this sort of analysis as well. So that's the other issue, is that there's no means of direct detection. We don't have a good culture.
Oh yeah, my question is for either or both of you. One thing this Lyme disease controversy sort of reminds me of is, I don't know if you're familiar with the PTSD controversy, diagnosing PTSD in the military. And if you think about, what is the reluctance of the military to begin diagnosing PTSD? Well, obviously it's a huge cost. There's thousands of returning veterans, and treating all of them appropriately would be an enormous cost. And I guess my question is this a matter of public health and the cost of public health, or is this just two competing schools who are just sort of dogged and rigid in their perspectives, like Kuhn would argue for?
Yeah, I think it's a lot of the latter, and for the former, I think that's true too, that, when you've got people who have their eye on short-term costs, like insurers, they have a really vested interest in making sure that they're narrowly defining the disease, narrowly circumscribing their treatment options. But on a long-term basis, if you're looking at, productivity in society, and, a lot of these people are unable to work and so forth, when you get somebody who's looking at both ends of the spectrum, they ought to be caring about treating it because it's one of the few chronic diseases that may be treatable. You know, most of them just go on till death.
Some of the problems I think associated with what you're discussing here are common problems to a lot of the major illness categories. I mean, a lot of illnesses affect joints, a lot of illnesses affect muscles, a lot of illnesses affect the neurological systems. And you get a syndrome of commonalities of expressed symptoms. But what most of these ailments, not as a viewer, as an uneducated viewer in the community, is that so often you end up with poor spokespeople for these confluences of symptoms. And so you end up getting people going, you know, it's the idea of, he's got more problems than he can possibly respond to. He's had problems since he's 15 years old. She's had problems since she went through menopause. And so the public looks at them and says, they're all quasi-nutsos. Give them a job, put them to work, and give them less time to complain about their problems. Like me, I work hard, so I work, forget the pain, move ahead with life. So these kinds of overlays, I think, get to the point you were making on societal perspectives, put them to work. If they got too much time to complain, put them to work. And where does truth and honesty and reality commingle in somebody that maybe just needs to work more versus the good science that draws it out and makes it apparent. Yeah, this guy's got a problem.
I can see why you would suggest that. There's some interesting, sort of relevant work with chronic fatigue syndrome where they've done treadmill exercise tests and compared, they're able to assess the oxygenation in the brain. And from what I've learned, that for most of us, when we exercise on a treadmill, we actually have more oxygen in our brain for the next 24 hours. Helps us think clearer. And for people who are diagnosed with chronic fatigue syndrome, at least in one study, they actually have less oxygen in their brain for the next 24 hours. So there may be some objective signs that we can measure to show whether people can actually.
If you get objective science, you're going to have all this overburden of too much time, too little work, a lot of interest, perseverating perspectives as an individual. You know, it just goes.
Well, this is a dilemma in working with people who have illnesses which also cause depression or at least depression symptoms, because they can look like it's just psychological, because it might be obvious that or they're misattributing things. They might be paranoid. They might have other psychiatric symptoms. And so part of the complexity of dealing with this is that it can be both. It can be that a person can have psychological problems, and they can also have what we consider a medical illness that is and so trying to tease this out is is really hard. Like with PTSD, the people try to detect malingering, and how do you detect malingering in PTSD? People have ways they try to do it. With Lyme disease, one thing that I've learned from people who do neurological assessment for Lyme disease, Leo Shea is one of them, that it's better to avoid testing people later in the day because people look like they're faking on the neurological exams, because people with Lyme disease tend to get really tired later in the day. And so to do an accurate test and not to falsely accuse somebody of malingering, it's important to do the testing earlier in the day. So it's an important question you're asking. I think the answer to it is going to have to be complex, because of the good
results. At least on the post-traumatic things that he's mentioning, there's some poor guy or gal who's been blown up in a vehicle on the road in Afghanistan. You've got some history of it and the damage associated with it.
Unless there's one more question that someone's dying to ask, I think we will adjourn.